Good morning, it's already good afternoon, ladies and gentlemen. Today it's my pleasure, together with Heinrich Heimann, guide you through the retinal detachment surgery, vitrectomy for retinal detachment surgery. We have a great panel: Grazia Petile from Verona, Lara Sandri from South Africa, Darius Schroff from New Delhi, and David Yorston from Glasgow. So now, this is how it is going to work. Heinrich and I will prepare the steps of the vitrectomy. We will wonder the steps are quite simple in the very beginning, but you'll see what different approaches our panel will have, and we'll ask the panel questions and ask them how they do the surgery and how they solve problems when they do retinal detachment surgery. So the first topic, obviously, is very, very simple: sclerotomy. I show the way I do it. I use 25 gauge vitrectomy for retinal detachments. The first trocar is radial, and the working trocars I do parallel. So my first question for Grazia is: do you also do 25 gauge vitrectomy, and how do you do your sclerotomies?
No, I usually do the standard vitrectomy is 23. I don't use 25. In fact, just for one reason, for the instruments, we usually use reusable instruments, and we have a whole equipment in 23, and we use disposable 27. So let me say, easy surgery, so to speak, easy surgery. Pucker or macula hole, we do 27, and all the rest 23. But for a practical reason, to be honest. And I usually do tangential. I'm a little bit afraid doing, I saw the technique that are supposed with horizontal, going down, and they are supposed to close better than the other. I'm a bit afraid that you do not know exactly where you end up inside. And so tangential, you know that you stay parallel to the limbus, and if you enter, if the sclera is thick or thin, it doesn't matter.
So you're afraid of an iatrogenic retinal tear? Obviously, it never happened, but otherwise I would have changed my technique. Any other approaches? You all go for 23 gauge. Does anybody of you?
Just on the video, you were putting well, not you, I'm sure, but somebody was putting the cannula straight in. And I always displace the conjunctiva with the tip of the needle in order to be able to place it off
This is what I at least tried in this case as well.
It's a simple thing to do, and it makes it that little bit safer.
So what's wrong in this case? I think it's obvious.
A bit too close.
A little bit too close, yeah. Okay, so at the end of surgery, what is your approach? 23 or 25? You all know the problem that we still have sclerotomies which are not tight. There are two camps we know: high pressure, low pressure. Do you massage? In which cases do you suture always, or just in special cases? Heinrich?
If the inferior breaks, I would suture. And I'm a 23 gauge fan as well. I think most people now do 25 gauge, I would say, for normal retinal detachment. I'm still a fan of 23 gauge, but you have more leakage. And what I usually do, take out weight and then re-inject with a syringe. Usually a couple of minutes later, it's a lot more sort of closed and tight system. But you know, it's not macular hole surgery. You need to be sure you tamponaded all the breaks afterwards. So I think it's important.
Do you make a difference between macular surgery and retinal detachment surgery?
Yes, yes.
Everybody of you agree. Great. So now two complications. A little bit similar to the case before. What happened? So you can see this is an iatrogenic tear in the posterior capsule. What shall we do?
I think David Yorston can answer that. You've been in that situation, haven't you?
Yes, I think it's one of my cases. I would probably, in this instance, carry on and deal with the cataract later, because if you leave these defects in the posterior capsule for a couple of months, then they become fibrotic. And you've got a reasonable chance of doing a phaco without losing the nucleus into the back of the eye. But if you can't see well enough to complete the operation, then you're going to have to do a lensectomy.
This is what I was afraid of, and I absolutely agree. If it's just a touch, it's just such a tiny cut, then you can continue, should continue. But in this case, I was afraid, and the view was obviously not perfect. We also had the cataract here as well. Here, this you can see, so I decided to continue, and I think I can proceed to the video. So in this case, it's really very important that you have a perfect capsular axis, because obviously the tear is going to enlarge, and the goal is to do a sulcus implantation and optic capture in the end, which I would like to show you. To the sake of time, go along until you can see the implantation in the sulcus. Obviously you need a 3-piece intraocular lens, and doing this approach you finally have a stable iris lens diaphragm, which is very important for retinal surgery. This is how it should look like in the end, and next time be careful.
And do you always do a biometry for every case?
Yes, we always do biometry for every case.
And in Lahrein, how is it in South Africa? Let's say Friday night, you don't have a biometry. What would you do then?
We would do our own biometry. So we do need to be competent in working our own equipment, and it does happen. So I will always have a measurement in theatre with me.
Okay.
If I don't need to proceed because the view is good enough, then yes, I would leave it, just as David said.
So next complication. Start the video again. It actually was a removal of silicone oil and now peeling. Cases long ago. I proceed a little bit, and the surgeon is focused on the center. Heavy liquid has been removed, and now look to the left. You can see here a choroidal detachment. So what would you do in this case? Nudity.
So I think we need to be very careful about placing our infusion cannula. And this probably has slipped out. So in this case, the beauty of our now MIVS is we can just interchange the cannula. So we can clip it, put it at one of the other ports and put it on. And that's fine. But always ensure the cannula is right inside. I mean, whatever you do, don't put on the infusion cannula till you see it's within the inside. And a small tip is clipping it on with a tape at the beginning of the surgery.
Okay. So, yeah, you also solved the question. It's obviously suprachoroidal infusion due to a luxated trocar. And as you recommended correctly, we don't press against like this. This is not the best way. Take it out, reconnect the infusion line to another trocar, and then increase the intraocular pressure. And what you will see right now, this is what I think is very impressive, that if you increase the pressure, you can also remove the valve of the trocar, so the fluid it disappears even easily, and at the end of the surgery, there will be no more choroidal detachment anymore. Any comments?
Yeah, you've got to be careful. If you do it with a fluid-air exchange, you can actually kill the patient. So a normal routine macular hole surgery can turn into an absolute disaster. So just like in this video, it usually takes you a couple of seconds to realize what's going on. But if it's under air, you need to stop straight away and rip it out or whatnot, because this can be life-threatening through the vortex veins.
David?
No.
Grazie.
Okay. Give you a freebie tip that sometimes you get these patients with a very bullous inferior detachment, and you want to put your infusion in infratemporally, but the tip of that infusion gets under detached pars planar epithelium, and you've got a subretinal infusion, and it's horrid. Simple trick. Put in your 2 superior ports first, and do a very limited core vitrectomy with air going in through one of the superior ports where it's not bullous. So you attach that anterior retina and then put in the infratemporal port, and it works beautifully. You avoid the subretinal infusion.
I think that's very, very important. About, I would say, let's say 1 in 50 cases, the retinal detachment does not stop at the ora serrata, but it continues into the ciliary epithelium. And if you haven't seen it, you don't know what's going on initially. So just like you said, never ever open without a clear view of the inner ring of the trocar. Yeah.
Ratio, one last comment. Now we switch.
No, I agree. It is important to check it. And if you know that it is just fluid, remove a valve, change the position of the infusion. And if you have a valve trocar where you can remove the valve, not every company produces trocars where you can remove a valve. It's very easy. You keep it open, and as we have seen.
Yes. So now about the
Wonderful result.
Mm-hmm. Yeah, sorry. There we go. Opening of the trocars, make absolutely sure they're clear. In pseudophakic patients, that's pretty straightforward. You can just go across. But in phakic patient, it gets a little bit trickier. In the old days, we used to start every 20-gauge vitrectomy with basically cleaning of the ports because vitreous could come out and go to the other side. David, do you still spend time on this, on cleaning the vitreous around the trocars?
No, not really. Sorry, no, not really.
Good. Laura, any other comments? Anybody spending a lot of time on it or not really?
Not too much time, but as you are removing your instrument, you can also keep it in the right plane and cut as you're exiting, and that will clear it off quite nicely without too much manipulation.
Okay. I think it's not you don't need a lot of time, to be honest. So I don't, but I think for the infusion line, it's really very important that you get free, because once you inject heavy liquid, so I think it's good invested time.
Yeah. No, it is. It's not as important because I think the iatrogenic tears from vitreous prolapse have basically gone from the switch to the trocar-guided systems. So what to do in phakic patients? Darius, do you have any tips and tricks? I would get nervous seeing this here, crossing the line. So a rule in our department is don't cross the midline in phakic patients, really, unless you really indent a lot. This is very close, isn't it? Any tips and tricks for clearing the trocars in the vitreous space, the anterior vitreous, in these cases?
I think it's better to definitely avoid crossing the lens. If it's really necessary, you can go on the same side, like you said. And most cases, I don't think it's really required anymore. The only exception would be if there's a lot of blood behind the phakic lens in a diabetic case, in which case then we may be a little heroic and do it. Or nowadays, we do a lot of combined surgeries for these cases, so that solves the problem.
Grazia, do you make a difference in cleaning the vitreous space between macular cases and retinal detachment, for instance? We're talking mainly about retinal detachment in this session here.
Yeah, I do indeed. In retinal detachment, I clear the anterior vitreous. I do at the end, not at the beginning, usually, the cleaning of the trocars. I think you can cross the middle line if you indent and if you use the direct light of a microscope. If you try to do it under biome of wide field systems, you really do not know where the lens is. Yeah. And another small trick I try to teach to my young colleagues, my fellows, is when you depress the sclera, keep the eye horizontal, because quite often fellows tend to rotate the eye, and you really do not know where the position of the lens is. If you keep the lens horizontal and you depress the sclera, and you depress enough and you look through the microscope, you really have an idea where the posterior capsule is and how far you can go.
And the age of the patient is important as well. So in an 80-year-old, the lens is far more posterior than in a 20-year-old. That also plays a role.
One small trick that can help is you can make a paracentesis and make the anterior chamber on deep, and then you gain a little bit of space in 2 millimeter.
I know of some surgeons putting a wick actually in that they have a constant outflow out of the AC to basically have a very flat AC. I haven't tried that myself, but some people do that. Yes. Okay. So now this happened that you have a little lens bite, so a lens touch. It usually doesn't happen with the cutter, but with the other instruments, either laser or here with a trocar. So David, back to you with your experience and lens injuries. So what would you do if it's just a touch? probably the same.
Thank you, Heinrich. Again, if you can see well enough to complete the operation, there is a lot to be said for just leaving this. Firstly, sometimes, surprisingly, the cataract doesn't advance that much. You just have a localized opacity, which in this case would be outside of the visual axis. Secondly, if it does get worse, if you leave it for a few months, you'll often get fibrosis around that defect, and you can do a normal phaco without losing anything into the back of the eye and put the lens in the bag. Whereas if you go straight ahead and do a phaco now, that tear is almost certainly going to extend. You're going to have to put a sulcus fixated lens in and do an elegant capsule capture like Sigi demonstrated.
So one word of advice, please note it in the notes, really, because some people say, oh, nobody happened, nothing happened, and you go on. And if you then the cataract surgeon doing that 6 months later, I've seen it, and then probably others as well, as soon as you just inject sort of after the rexus, boom, everything.
But that's the other alternative. You just fill the eye with silicone oil, then the cataract doesn't advance at all, and send them somewhere else.
Yeah, so make a note, and if you list that patient for phaco, be very, very careful, really, with your hydrodissection, and you can just ping open everything just with one injection of fluid. Okay, great. So we all agree. Sigi, you too? Would you do anything else? Or
yes, of course, absolutely. Just you can go forward. So once more. So this is not the same patient, but I just wanted to show you. In this case, we have a trauma patient, and you see what happens if it's just a small defect. You get a fibrosis around the defect, and after years, when this patient develops a cataract, you still have a stable posterior capsule and can just do a normal intracapsular implantation of an intraocular lens.
So David Yorsten is right again.
David Yorsten is always right.
There it is. Okay, so detachment of the anterior vitreous. Do you spend any time there, Grazia, in the anterior vitreous for retinal detachment? Or is there a difference between pseudophakic and phakic patients?
No, usually I don't spend too much time for anterior vitreous. For the pars plana, the periphery, the trocars, and quite often automatically it comes off of the anterior vitreous. Nevertheless, I have to say I do not spend too much time, but I'm quite annoyed when I see the patient post-op and I see that there is some vitreous left behind the capsule, and I'm a bit irritated, to be honest.
The good thing is, if you do it, you really make sure that the complete anterior vitreous is gone. In terms of PVR development, whatever. If it's chronic case of retinal detachment, I always try to do it. The big question is, shall we do it in phakic patients?
Yeah, I mean, I learned in Rotterdam from Jan van Meurs that he was very aggressive in pseudophakic patients. The idea behind it is that in pseudophakics, you know, the detachments are slightly different. They have more small breaks close to the aura, more anterior, and the idea is that you got this ring of vitreous pulling forward, and that you have to break that cycle, so to say, to get through there. Laura, do you make any difference, or you do the same basically in phakic and pseudophakic?
I think the time I'll spend the most attention or give it the most attention is in a diabetic, because you just need a small bleed, even if they're phakic, and you get this veil in the vitreous of blood, and it takes so long to clear, and then very often it's a reoperation. So it's the one time I will spend a lot of time looking at that, even though it can be nerve-wracking in a phakic patient.
And Grazia, I watched the beautiful surgery in your hospital. You are very particular about the vitreous space, aren't you? You remove every fiber, don't you?
Yeah, especially
almost,
in complicated, almost.
Do you make a difference between pseudophakics and phakic patients?
Yeah.
You're more aggressive in pseudophakic?
I'm more aggressive in pseudophakic, although you can remove it in phakic patient as well, especially sometimes. I don't use Canalog in all the detachments, but if you use Canalog quite often, you can see where the anterior vitreous is. And of course, it is important not to have the opening toward the capsule, but to stay 90 degrees, and so you really can aspirate the vitreous alone and not the capsule. And so you are pretty safe. You can detach also in kids safely, phakic kids. So it is possible, but when I think it might be important, not in every case, just as an exercise.
Okay. Okay, thank you.
So we move to posterior vitreous detachment, obviously very important. Does everybody of you use triamcinolone? First question, second question in every case. Laura?
No, I don't. I think with our smaller gauge surgery, it's becoming easier and easier to detach that face. But if I am battling, then I will stain, and it won't be triamcinolone, it's usually blue.
Do you use a special triamcinolone, the Triessence, or do you have any sort of licensing issues or concerns, or just a normal orthopedic out of the box?
That's the one that we're using. No licensing issues.
So you're not worried about vitreouschisis? This is what I'm really afraid of. And as you can see in this case, you can see that there's a vitreochisis, there's still vitreous attached, and the posterior vitreous hyaloid is gently removed. How much time do you invest in this procedure, if at all? And in which cases?
So very slowly to release that hyaloid, and it depends if I'm treating a retinal detachment or if it's macular surgery. So with the retinal detachment, just being thorough to make sure I've identified the break, and then spending time releasing the vitreous if there is breaks in that area. I'm not going to chase vitreous where there's no pathology. I don't want to induce unnecessary breaks. And yes, then I would stain and look.
Okay.
I think
Katja? Oh, sorry.
I spent a lot of time only in high myopic eyes.
Because I have the impression if you have beginning PVR and you do this procedure, then the problem is solved. There's a maximum reduced risk of PVR development.
This is something different. If you have a beginning PVR, every time. But in primary detachment, some colleagues of mine use triamcinolone every time. But I don't think it is really helpful and necessary in a primary detachment, because it is true when you see this cortical vitreous, you think it is dangerous, it might promote PVR, but all the buckles we did, and still do, we do not remove a cortical vitreous, and there is no increase in incidence of PVR if you close the break. So
we agree
I'm
on
not convinced that you really need to remove a cortical vitreous in all the cases.
Except
if you
PVR.
have a PVR and high myopic eyes, because the contraction may cause additional breaks, and the retina is thinner.
Koen Overdam had published a paper. He's using the swiping technique. For those who don't know it, you use a little bit of sponge and then gently remove the posterior hyaloid. And he published a paper where he had 100% success rate because of having removed all the vitreous. What do you think about it, Darius?
I think you can even use a finesse loop. I mean, this is a fascinating technique, but if you don't want to do this, you can even use a finesse loop or Tano, because we reuse a reusable Tano and do this. I think recurrent, like Dr. Gracia says, high myopes is the case where we'd like to use tricort and recurrent detachments.
So David, your our complication specialist, would you think you could increase your success rate up to 100 doing this case?
Thank you for that, Siggy. I don't do this routinely. If I've got a patient who's had a really bad outcome with a detachment in their other eye, they've gone into severe PVR, and it's gone really badly, and they then detach in their good eye, that's when I use the triamcinolone. And I haven't had to do that very often, but I have found vitreous cortical remnants, and I have peeled it. And so far, it's worked.
Yeah, I don't know the exact frequency Koen has described. I think it was quite high, and when I heard about his 100% success rate, I came home and did it on every case, and the first 10 cases had nothing left. So it's not that common in at least the patients we see, I have to say.
So Heinrich, just a normal retinal detachment case, you will see I don't use triamcinolone, but I still have learned that I have to detach the vitreous and get rid of most of the vitreous, and now you will see what happened. On the opposite side of the retinal detachment, I'm inducing tears. Would there have been a way to avoid this complication? Because I'm still at the equator, I'm not in the anterior part of the.
Well, yeah, what to do here is probably the most difficult question to answer in retinal detachment surgery. I don't think you can avoid it, but we all had cases so that we started with 3 breaks and ended with 15. And at the end, you ask yourself, why did I choose this profession, really? And it does happen. As soon as you see this happen, I think I would switch to trimming only and not trying to detach any further. It usually is when you have quite a central vitreous base, really. Grazia, what would you do?
No, indeed. If you can suspect this when you have posterior breaks, you have maybe a couple of breaks close to the equator or even posterior to the equator, and then you can think that indeed the insertion of the vitreous base is very posterior.
Is it okay
in
to
some
leave
cases,
vitreous?
it's not difficult to really prevent it. In some of these cases, I put a buckle. Not very often because we really tend
additional pupil?
Additional. If I see that the vitreous base is posterior and contracted, I tend to put it before the vitrectomy because it is annoying to put a buckle afterwards, and you tend to be not to do it, in my experience. Indeed, I would have put probably perfluorocarbon in and just shave at a level because otherwise, when you see this kind of retinas,
I think it's,
you really need to treat with respect, so to speak.
I think it's most important to get rid of all the vitreous then 60 degrees, 360 degrees, and you can just proceed as normal. Okay. I would say this is something which also can happen. Luckily, it's not my video. You saw this direct trauma of the retina and the choroid.
And mine.
But this time I'm gonna ask Darius, what would you do if something like that happens? This surgeon obviously was trying to get rid of all the vitreous in this area. He was successful, but he also removed a little bit of the retina and the choroid.
Yeah, sometimes less is more. But yeah, I think this could happen with anybody, but more likely with the beginner. You just raise the bottle height, and then I continue as before, and some laser around that. I think that's about it.
Okay, so there was happy end, and everything was fine. You can just treat it like a tear, but make sure that you correlate the choroid.
Yeah, so one rule for us is it often happens when you talk to someone or so, because you don't have any manual feedback from the trocars, which you used to have in 20 gauge. So one golden rule in particular for beginners is when you not look through the microscope, everything has to be out of the eye. So never have any instrument in the eye without direct eye contact, really, and visualization. That's important. And if the closer you get to the posterior pole, I've seen that as well, be aware they can develop a CNV later in that break there. So you need to do early OCTs. If you then treat with anti-VEGF, they may have a good outcome, but don't miss that.
And if you have a posterior break choroidal damage and you do have amniotic membrane in the OR, use it to protect this area, because in
amniotic membrane.
Amniotic membrane prevent this complication if you have it in the posterior pole. No, this is in the periphery. No, it is in the periphery. Okay. But if you have it in the posterior pole, I will have done it.
Yeah.
Because CNV is quite usual, quite frequent in these cases.
Okay.
Okay, so heavy liquid, that's a nice discussion really to have. I'm a heavy liquid user. David, are you, or Grazia, or?
I am.
Yeah, so the trend is less and less really heavy liquid. The idea behind it is 2 things. Number 1, the subretinal PFCL, which we show, but number 2 also that basically reattaching the retina too violently may sort of lead to a disconfiguration and then metamorphopsia and basically the mini rotation that you can get. Now, that was what your lecture was on, David. Where are you? Can you sort of enlighten us on the heavy liquid use? Is it good or bad in the BEVIS database?
As you know, I'm a great enthusiast for reattaching the retina within the first 72 hours.
Okay.
But reattachment means macroscopic reattachment. Mm-hmm. And you can leave a little bit of subretinal fluid posteriorly, what we might call microscopic OCT, reattachment can happen more slowly. And that's probably a good thing. And generally, in macular off detachments, I'm very relaxed about leaving a puddle of subretinal fluid at the posterior pole. I'm confident that when I posture the patient face down, that fluid is going to go, and we'll probably have a slightly better result than if I slap the retina back on hard.
For how long face down and straight after surgery?
Immediately after surgery.
For how long?
We use 4 hours, but I know other people who use 2 hours. The original trial used 24 hours, but I think that's too long and too difficult. But 4 hours certainly appears to work. Whether or not you get the really good apposition of photoreceptors that avoids metamorphopsia, I think is in some doubt, but you certainly prevent macular folds and major shift of the retina.
I think it's a really great discussion going on right at the moment, because we have the 2 reasons, but we have a third reason as well, a legal one. So the legal one, we have to think of getting rid of the but the major reason we use PFCL is not just to reattach the retina, but also to stabilize it for shaving the retina. And lucky us, with the new techniques, this is probably not more that necessary than.
So what's your approach? Use it in every case, or try first without it and see how you go, or what would you say?
That's my approach. But obviously, it's much easier with heavy liquid.
Yeah. Darius, how often do you use heavy liquid?
So I'm of the less and less camp. I'm using it less now because of these complications. And what I find is that you don't always need it. Sometimes we did the sandwich technique where we put PFO at the back and then did a fluid exchange. Now I kind of just turn the patient's head and make the break dependent and then drain. And of course, when you tilt the patient's head, you have to kind of move the microscope a bit. So it just takes a few seconds. But I think just tilting the head allows me to get away without PFCL.
Laura, which PFCL do you use? Do you have a particular preference, or?
No, whatever we have available we will use, but we use it very sparingly. I usually reserve it for endo resections, or like the case earlier we saw with the iatrogenic breaks and you really want to shave, then I'll use it. But otherwise, I do try avoid it. I use intraoperative positioning to drain large amounts of subretinal fluid, and then posturing 2 hours face down after surgery. And if the patient can handle longer, we'll push for longer, but it's on an individual basis.
Grazia, we seem to have less and less problems with these bubbles. They were like epidemic 10 years ago or so under the retina. Now it's less, I think probably through the valve trocars, you have less rotation. Do you have any tips and tricks how to avoid small bubbles going under the retina?
Yeah, 2 things. I think it's not less with the trocars, because you have the trocars going into the bubble sometimes if you feel completely in the eye, while with a sclerotomy the level was higher. So I think it has increased. It is less and less because we learn how to deal with. Be careful not to lift up the level of PFO too much unless you close really the infusion and cannot migrate in the infusion line. And clean all the bubbles before starting to go into the periphery and under the level of the break. And the other important tip is with some machines, when you depress the sclera, you have an active control of the pressure. So use low intraocular pressure and pay attention, switch off this function, because if you release the infusion, sometimes you have a very rapid jet of fluid that creates a lot of bubbles and they might migrate under the retina.
So David, here is an injection and a tear through an injection from heavy liquid. Any tips how to avoid that?
I'm delighted to say that this is a complication I haven't experienced.
You sure?
The previous question was how much PFCL? And the answer to that is 0, none. Okay. So don't use PFCL and you won't get this problem.
Excellent. You're more cool if you use less PFCL, aren't you? You feel it's okay. Yeah, no, that's fine. Any other tips and tricks on PFCL? Ziggy? I don't know.
Yeah.
How to avoid this problem?
This is a syringe type, so you need this should never ever happen, because usually you screw it up. How do you call it in English? You have to fix the needle with a special suture,
Yeah.
That's future with the special syringe.
Yeah. The Lurlock syringe.
The
yeah?
Linux syringe. Thank you so much. This is what I was looking for. Then it would never ever happen. Just as a reminder. But I think nowadays nobody does use the old ones anymore. Hopefully.
Yeah, but
So the tip is if you want to avoid these bubbles, just increase the intraocular pressure when you inject the heavy liquid. Then you don't need a lot to stabilize. You just have to stabilize the retina. So you don't need really fill up your eye. Just I would say at least half of the eye is more than enough. And then you most of the time avoid the bubbles under the retina.
Yes, and one trick is look at the trocars. They should not be leaking. If you got a particular manufacturer that has lots of leaky trocars, get rid of them, because what the leakage does, as soon as you go out of it, you got like a washing machine effect, and that creates lots of small bubbles. It was a problem when we had non-valve trocars in the beginning, and that was a lot worse really in those days. So Lara, this is a redo then that happened. How can I sort of prevent it, but what would you do in these cases?
So prevention we've discussed, but just another point is, especially when you've got a large break like a giant retinal tear, be very cautious with your indentation so you don't create turbulence in the eye.
Yeah.
I think that's a mistake as junior surgeons that we make, or you just want to recheck something. Don't forget you have heavy liquid. Only up to the break, as Gracia's mentioned as well. And then post-operatively, if you do see this, there are many different techniques, and I know David Wong's described a few. Transretinal drainage of this doesn't seem to be effective. You just create a macular hole. So it is a difficult situation, and very often what I do is put percutaneous fluid there again and do a transretinal aspiration then with it there.
I think the most important thing is that you do it very quickly. Don't wait weeks, even not days. If you see it, do it.
Yeah. Okay. PFCL-free detachment surgery, I think we all can do it. My advice would be remove the vitreous opposite the retinal detachment first, because usually the subretinal fluid under the detachment is thicker, like glue, and you got one good chance of getting it all out in one go with your cutter with active suction, rather than if you start doing your vitrectomy there, a lot of it would have been replaced by fluid, and that's more serious and it's more difficult. So that kind of get that glue out in one go makes it easier for me with active suction. Darius, do you use active suction if you do surgery without PFCL?
No, I generally just use the flute needle, but I know that people are using it effectively, but I just use the flute.
David, do you use active suction or just the fluid needle to drain if you want to avoid
I use active suction. We just recently swapped to a Dork machine, and they have a setting on that is very low flow for air fluid exchange, using a peristaltic pump rather than the Venturi. And the key thing to this is slow aspiration of the fluid, and you get much more that way because, as Heinrich says, there's a lot of protein in that subretinal fluid to start with. And so when you start pulling on the subretinal fluid, the other end is the sort of that's posterior is attached to the protein. You're pulling it all out, providing you do it slowly. If you do a rapid air fluid exchange, then the break gets slapped back onto the pigment epithelium, and all the fluid is then loculated posteriorly. Now, that's not disastrous. If you do leave a lot of posterior fluid behind, don't do any damage trying to get it. Just leave it there, posture the patient head down, it'll be fine. But it looks nicer if you can get more of the fluid out.
So we are getting to the shaving of the vitreous space. Just show you a few techniques how we can do that. We can use a chandelier-like, as you can see here. We can do it with indentation by retro-illumination. It's the cheapest possibility. We can even get it cheaper. Wilson Wong introduced this technique he uses a cotton wool and the light source, and then is indenting. You can see the vitreous space and can shave very elegantly.
It doesn't work with wooden cotton buds.
Yeah.
I found it out the hard way.
Okay. So thanks to Wilson. And yes, you can do it under air because you have a wide angle effect, and then you can remove the anterior vitreous. And last but not least, you can do it from anterior. The vitreous is you can see it very good, but you have to get trained. It's not that easy to do it from anterior. But in my hands, at least, if you want to make sure that really everything is gone in PVR cases, then I've finished my case with this technique. So, guys, 2 questions. Question number 1, do we have to shave the vitreous in all retinal detachment cases? And how do you do it?
Lara?
Now, question number 2.
Okay. I shave the vitreous from around the breaks, but I'm making the assumption that if the vitreous detachment hasn't caused a break anywhere else up to now, then it's unlikely to in the future. And so I shave as carefully as I can, fairly meticulously around the retinal breaks, but I don't worry too much about doing a meticulous shave everywhere else.
Sarah?
So
It's
generally,
time that you all can answer. Don't worry. We have enough time.
So I'm quite particular about removing it from everywhere, and particularly if I find there's something inferiorly which is not supported, I would add a belt buckle for that area also. If I feel I'm not able to sufficiently shave it, I would put a 240 belt buckle element along with the surgery
Okay.
to support the vitreous base in certain cases.
Do you think it's necessary?
I think in certain cases like high myopes or where there is a very posterior vitreous base, I think it's necessary.
Heinrich? Combined surgery?
I wish
Another
that
topic?
we could answer that question before I die, really. I really don't know the answer. And we got very good surgeons who do minimal vitrectomy, really, and very good surgeons who do almost complete vitrectomy, and truly 100% believe that if you don't remove as much as you can, you increase the risk for new breaks. It's the old question, if you're too aggressive, as we've seen in the video before, you can cause breaks doing that. And on the other hand, once you got a redetachment and see a break with a little bit of vitreous attached to it, you always think, oh, if I would have removed that vitreous, you probably wouldn't have got the break. So I cannot answer that question. I do what I was told, and that means I do a kind of okay vitrectomy in macular cases, but in retinal attachments, I try to remove as much as I can, not knowing whether that is necessary or might even cause more problems. I really don't know.
That's also my approach. Sarah, South Africa. But I know you learned somewhere else.
So I definitely spend the most attention over the areas of the breaks, and I think just such careful examination that you're not missing something or a break where you should be shaving more meticulously. But I tend to not be too aggressive in my shaving if the area appears to be normal. But obviously every patient's different, and sometimes you have these really broad, sticky bases to the vitreous, and then I will spend more attention. So it just depends on the case.
What is your favorite technique for shaving?
So we have African patients, so the choroid is dark and retroillumination just doesn't suffice. We also don't necessarily have nurses who are trained in indentation, so I will do it direct in those cases.
Heinrich, your favorite?
My preferred method actually is with the backhand, so trying to stay on the same side and tilt the eye a lot. Under the microscope, if you follow, you can remove a lot of vitreous just by using kind of the backhand technique. So you turn the cutter and go up to 6 o'clock on both sides. In retinal detachment, that's more of a challenge because you got a higher risk of getting the retina into there. Then I use the indentation technique with a light pipe usually, and I find that very useful. That's my favorite technique. David Yorston, Beavis database, laser cryo. What's the verdict?
We have to call it the Retina database at this meeting. The verdict is that there is slightly better results in eyes that did not have laser. But although that's multivariable regression, it's difficult to exclude all of the factors that make somebody use laser rather than cryo. And chances are more complicated detachments with more breaks and needing 360 retinopexy, they're more likely to have laser. Overall, I think the evidence is now pretty good that if there is any difference between laser and cryo, it is very, very small. It's very difficult to absolutely prove there is no difference, but every trial that's been done has failed to show any significant difference in outcomes between cryo and laser. So I think use whatever you've got that works.
Yeah, that's the point. I'm a cryo man if it works. If it doesn't work, I start screaming, and it's terrible. So the best phase were these single-use cryos from BVI that unfortunately were taken off the market, and then I was a really happy cryo man. Lara, who are you? Laser cryo?
No, I'm cryo, Prof. You know that. Originally, the person who trained me in South Africa also was pro-cryo, then in Liverpool, but I just find if there are few breaks, cryo is great. Obviously, if you've got more breaks, then we need to use laser, and also it's very cost-effective for us. It's a probe that we can reuse.
Okay. Darius, what do you use in India?
So, I'm on the opposite camp. I'm a laser man. So
Yeah,
it's laser all the way
man
for me. Yeah.
It's
Me
because
too.
it's slick, or what?
Me too. I think that the trauma you put is not even if, especially in large tears. I prefer the laser. I sometimes use the cryo as well if it's difficult to read the tear. Or if the retina is still detached, then cryo is obviously the better option.
Can you bill it differently? Can you?
This is a good question. I'm not in a private setting, so I don't have to ask myself this question.
In South Africa, can you bill it differently or no?
It's the exact same price, actually. It's just that your laser probes, obviously, you would need to replace compared to a cryo probe.
So how do you do it? Do you do continuous? Do you do single spots? Very white, very gray, or just visible?
I wouldn't do a triple thaw. I think that's overkill. I'll do a single thaw. And
Okay.
as soon as it covers the edge of the breaks, maybe 0.5 millimeter further, and that's when I'll abandon.
And laser in African patients probably is a bit more of a challenge. Do you have any burns or any tips and tricks how to avoid? How do you gauge that?
Very low settings as well because of the dark choroid, and just marking your breaks because you lose your breaks very easily.
Do you mark, Darius, do you mark your break before laser? Or
Most cases I do mark, especially if it's the tiny breaks. I would like to mark those breaks.
360 laser?
In most cases, yes.
In most cases?
Yes, yes.
Do you do 360, David?
I do 360 laser in all cases in which I'm using oil because there is some weak evidence that reduces the risk of redetachment after you take the oil out. Well, you will often find when you put in oil, particularly light silicon oil, that the inferior third, the inferior 25% of the retina redetaches, and you're going to have to go back and do a retinectomy. I think if you've got 360 laser on, you probably limit the size of that so that it makes your subsequent surgery easier. But otherwise, I certainly don't do it as a routine.
I think it's...
And there's no evidence that it reduces the failure rate if you do it as a routine.
And 360 at the aura, at the equator, or in between? Where?
I tend to do it at the equator and slightly anterior from the equator.
And ciliary nerves, they included? You burn over them, or do you... The ciliary nerves, some people say you can get anterior segment ischemia if you laser the ciliary nerves. Do you take any precautions?
I try not to laser them that heavily.
Okay.
The idea of the laser is not to create a white, full-thickness burn, but to just increase adhesion. One of the things that intrigues me, and a guy called Wilson Herriot in Australia, who has been working on this for years, is the fact that when you do laser in retinopexy in an eye that is not detached, you don't have to put a tamponade in. You just put laser around the break, and in the vast majority of cases, you don't get any progression. It all goes well. And his point is that it's completely dry. There is no fluid there at all between the RPE and the retina in those attached cases. He's saying if you can get it that dry at the time of surgery, then you would be able to do a vitrectomy and laser and no tamponade, and then I would switch to laser.
I've seen it 10 kilometers away from here. Vicente Martinez Castillo
I
doing
think he's
that.
about to start trials.
Yeah, it's really super impressive, I have to say.
But it's very hard to decide when to do it. This is what I would be afraid of. No? It's very hard to decide then what's the right case to do it, because the risk of redetachment is
That's right. I
high.
always say next week I'm going to do it. Next week, and then you never do it. And it's not a problem putting an air bubble in, what a lot of people do nowadays. Okay, I think we need to move on, Ziggy. Yeah.
The videos were just showing the different techniques to indent and to perform the laser treatment.
Yeah.
Fluid exchange. We have covered this topic a little bit already. Obviously, we want to get rid of the subretinal fluid. So we go there with our fluid needle, fluid exchange. And as David just mentioned before, it's not, nowadays we know that we don't have to get rid of all the liquid. So how much liquid is okay, Lara, sorry.
So I think the way I approach the subretinal fluid is I leave it until last, because that nice sticky fluid just helps you reattach that retina if you've got a superior break with a bullous detachment inferiorly. And then I'll basically drain until the break flattens and leave it at that. I won't chase it further beyond that. So every case obviously is different, and it is frightening to watch a big bleb of fluid under the retina, but it is gone the next day. I rely more heavily on my posturing rather than trying to get every last bit out.
Is your posturing procedure dependent on the amount of fluid you have in the end, or do you always do the same?
I will always do the same and posture them face down, and then according to where the break was.
So are we all in the posturing face down camp? I am.
I love it.
Henrich? Darius? Yep. So we have to invite somebody else next time. David, you.
Sorry, I missed the question, but just a comment on the subretinal fluid drainage. How many people on the panel would do a retinotomy if there was incomplete drainage of the fluid?
I don't do it. I'm afraid of it, but my colleague Karl Gronwald does it regularly. And I was always concerned of PVR, but it doesn't happen. It's quite useful. I don't use it personally, but I know people who are very successful with it.
I have some breaking news on that. We've analyzed the cases with retinotomy in the Beavers database, Uretina database, and found that the outcomes are exactly the same, except epiretinal membrane is more common if you do a retinotomy.
Okay.
So it may be a case in which you might consider doing a prophylactic ILM peel if you do a retinotomy. Second breaking news is we've looked at the post-RD study, and this is a trial that looked at immediate post-op positioning after retinal detachment surgery, and it's on that basis that we're all posturing people face down. And we found that when you looked at the amplitude of shift, not just whether or not there was any shift, but at how much shift there was, you got significantly less shift in the eyes that were postured face down and had a posterior retinotomy. So it does seem to have some benefits.
Okay. But the idea of doing the retinotomy is just to get rid of the subretinal fluid, is it? The idea of doing the retinotomy is to get rid of, completely rid of the,
exactly.
Which we mean when all this normal is not necessary at all.
It doesn't kind of sit well with what we've been saying about leave a bit of fluid behind. And the answer is we don't know all the answers yet. We're still learning.
Yeah.
So now, kind of a complication. What are you doing? As you see here, the vision is reduced, and what would you do in this case? The reason for that is the water condensation on the surface of the intraocular lens. Darius?
I think it's a simple thing of just putting a little bit of viscoelastic behind the lens should kind of suffice in this procedure, in this case. Yeah.
So this is what I did, and just a few seconds you will see how it works. Darius is correct, and Darius, now it's your turn. And beautiful vision again.
Yeah.
Darius, could you come up?
Yeah.
We want to. It's your. This is now. Is your video? You can get up. You can stay there. Whatever you prefer.
Okay.
I get the video running.
Yeah. So this was a patient where We did this fluid air exchange, and this was already a vitrectomized eyes. So this was a patient where we removed the oil, and we were doing a resurgery. And if you just have a look at the lens, like in the previous case, I said, it's very simple. Just put a little bubble of visco behind the lens, and everything's fine. But you can have a look here. I mean, it just doesn't go. It doesn't get better. And in fact, the reason I want to show this case was to kind of get the panel's opinion on what would you do in this case. Because if you see the bubbles, they seem to be almost embedded in the material of the lens. Would you like me to come there and fast forward it a bit? Yeah, you can fast forward it. Okay, fast forward.
Actually, this is the reason why I want you to come forward. Yeah. Okay, you can do it.
So basically, I think we did every trick in the trade. We put a cutter behind it. We tried to remove it with the cutter. It just wouldn't go. And we redid the surgery. We kind of went back again and did it, but nothing helped. So when we go back to fluid, we find that it would clear. But the moment we do a fluid air exchange, it will become horrible. So finally, we had to explant this IOL. So my question did this material get embedded in the silicone lens itself, or what is the reason why nothing worked? Putting visco, putting fluid, directing the infusion cannula towards this, blowing air onto the IOL, nothing helped in this case.
I think as an absolute last resort, you could fill that eye with heavy liquid and then do a direct exchange if it was a case that required oil.
Okay.
And that would give you a clear view until the end of the surgery. But that is extreme.
Okay. Dr. Yosten, anything?
I think it would depend a little bit at what stage this is. Have you already done the retinopexy?
Yes.
Fine. In that case, what you're worried about is if you just put in a gas bubble at this point, you're still going to leave a lot of subretinal fluid behind. But that doesn't necessarily matter.
Okay.
One way of doing this would be to put in a small volume of 100% gas and do what you might call a pneumovitrectomy or a small bubble vitrectomy.
Okay.
And you just accept that there's fluid there. The other way would be just to put in a slightly expansile, so maybe 30% SF6 or something like that.
Okay.
And accept you're not going to get a complete fill, but rely on the posturing and the expansion of the gas to get rid of all of the fluid.
Okay. I think it was because of the material. It was a silicone oil lens, and it had an oil debris lying, which just got accentuated with the change.
Thank you. Great. So the last topic really on that would be silicone oil tamponade. I think we learned during this year retina, more and more people going away from silicone oil in retinal detachments if they can avoid it. It seems to be, as far as I heard, lower vision associated with it. In the Retina database as well, David, in primary cases, silicone oil, no?
What the Retina database shows is that light oil is strongly associated with a risk of reoperation and failure. Heavy oil is not. So I think what we're seeing is definitely a move away from light oil, if we can avoid it, and probably we are becoming less reluctant, or certainly I am becoming less reluctant to use heavy oil in patients with predominantly inferior pathology, because we know they don't do well with gas.
How to avoid underfill, Laura? What are your tips and tricks if you fill it?
If there is a lot of subretinal fluid, you might run into trouble. So maybe being a bit more meticulous in your air fluid exchange and getting rid of that. And then at the end of your tamponade, seeing that the eye is full and maybe suturing your ports if you don't have great closure. And you're leaking, so especially in your 23 gauge surgery.
Do you suture all silicone oil ports or occasionally?
I'm predominantly on 23 gauge, and so yes, I don't like to take a risk, especially if I've got breaks inferiorly and I'm going to be relying on a little bit of posture and a really good fill. I would definitely then suture those ports.
Ziggy?
Yes, I absolutely agree. It doesn't make sense to be the hero, to try to be the hero. In the end, you will have silicone oil under the conjunctiva. Nobody's happy.
Darius, how do you avoid silicone oil in the anterior chamber? That is sort of at the end of a long surgery, the worst thing you see. What do you do? Any tips and tricks for that?
So if you're worried about the lens being mobile or we sometimes put visco in the AC before doing the fluid air exchange. And the other tip is to make sure that we're always so particular about having a full fill that we don't realize how hard the eyes become and how much oil we're putting in. So keep maybe just a finger on the side of the eye to make sure the eye is never really hard when you're inserting the oil.
Mm-hmm. Do you do direct exchange, heavy liquid against silicone oil? Or?
Yes, I get the retina flat with air because if it doesn't flatten with air, it's not going to flatten with oil.
Yeah.
So flatten it first with air, and then you put the oil in. And I just put the oil in through the main infusion usually.
Mm-hmm. So the question is, when do we do direct exchange? I think if we have slippage, we have to do it because then the air isn't working. Then we have to do direct PFCL silicone oil exchange. Do you have other indications where do a direct exchange, Laura?
On endo resections, we do our direct exchange because we wouldn't go into air, the risk of an embolus.
Yeah, and for slippage, it's a good thing if you know how to do it. It's not that easy. You need to have a robust system to be able to do it because in some cases you're forced, so you have to. Okay. Do you use myocol before silicone oil exchange to avoid sort of silicone oil coming forward, or do you think that's a hoax? That doesn't help really. Oh.
It's not something that I routinely do.
Mm-hmm. Ziggy, and other tips to avoid?
It sometimes makes sense to inject some air in the anterior chamber.
So what if at the end of the procedure you see silicone oil in the anterior chamber? What do? Just go home and...
Honestly speaking, I think it's just, if it's not too much, I just leave it and wait 1 week, 2 weeks. Yeah. 2 weeks and then remove it.
Okay. So earlier removal is the key. Darius, any tips and tricks for that?
I think it depends on the quantum of oil. If it's just a tiny bubble, you can observe it. But otherwise, other trick sometimes is we've tried in certain patients where we dilate the pupil with Tropicacil Plus in front of us and make them position. And in a couple of cases, it's migrated back. But that's far and few.
Okay. You want to close?
Close the session. We're running out of time. I'm so sorry. Obviously, we could talk about each topic for more than 1 hour. But last but not least, I'd like to ask you guys, but also you and everybody in the panel, having now been with us, are you thinking about changing your technique? Have you learned something, David, to avoid complications for the future?
Yes, I've learned that it's best not to put a needle into the lens. And thank you for pointing that out to me.
Okay. So what about you? Have you learned anything? Are you going to try something different now? Hands up. Shall we do the course again next year? That's the question, actually.
Yeah, remember, the most dangerous time for the patient is the surgeon coming back from a conference.
Thank you so much. Safe trip back home.